Hello everyone. So I'm today going to speak about oral potentially malignant disorders. I'm Dr. Jiji George, Professor and Head, Department of Oral Pathology, BBD, College of Dental Sciences, Lucknow. So potentially malignant disorders are a family of morphological alterations which have an increased potential for malignant transformation. They're also indicators of risk of likely future malignancies elsewhere in the oral mucosa, that is, in the clinically normal appearing oral mucosa. Now, there's a small change in the naming structure of these lesions, nomenclature of these lesions that has taken place. Earlier, they were called as pre-malignant lesions and pre-malignant conditions. Now, they are called as potentially malignant disorders. All of them are grouped into one. That is because it was found that the pre-malignant lesions and conditions, all of them did not transform into malignancies. Instead, some of them did and some of them did not, because changing into malignancy is a multifactorial process. So the WHO decided that they're going to just call it as the disorders which carry the potential, which have the potential to change into a malignant disorder, but need not necessarily do so all the times. So that is how the word potentially malignant disorders came into being. Now, the severity of the dysplasia is a gold standard predictor for oral potentially malignant disorder progression. Now, what I mean by that is the severity of dysplasia is dysplastic features. There are a group of dysplastic features which we will be discussing in this lecture. It's a gold standard predictor. That means just looking at the patient clinically, we cannot predict if the patient is, the lesion is going to undergo a malignant change. But if you take a biopsy of the lesion and see it under the microscope and you see dysplasia, depending upon what kind of dysplasia or which grade of dysplasia is present in the lesion, you can actually predict if it is going to form a malignancy later on or not. So there are cellular or molecular markers or gross chromosomal changes, that is the ploidy status, which can be used to predict the cancer risk of OPMDs. Now, to talk about the ploidy status, we have diploid and aneuploid status. So I'll come to that later. So to see these ploidy status, we can either do a flow cytometry or an image cytometry to measure the DNA nuclear content as a surrogate marker of genomic change. Now, there are different things which we have to understand here. As a clinician, when you're working in the dental clinic, when the patient comes to you on the chair side, you can just see the clinical lesion or perhaps do some chair side techniques and understand whether it's going to undergo a malignancy or not. But you cannot be completely sure. So the actual marker for a malignant change would be the DNA content. So the DNA content can be seen inside the nucleus. So we need to do some studies in the genetic level. So flow cytometry and image cytometry are two different processes or methods using which we can measure the nuclear DNA content or the ploidy status as a surrogate marker in the genomic damage of cells, which probably the cells have undergone. So what is polyploidy and what is aneuploidy? Polyploidy refers to the presence of multiple copies of DNA in excess of the baseline diploidy. Now, we all know that human cells are diploid in nature. That means we have one chromosome from the father's side and one chromosome from the mother's side. So polyploidy is nothing but the presence of multiple copies of DNA. And aneuploidy is a result of unbalanced chromosomal segregation. That means when a cell undergoes mitosis, you have two daughter cells forming. So both the daughter cells will have equivalent amount of chromosomal DNA content from both the mother and the father. But aneuploidy means that there's an unbalanced segregation. Some cells have got more chromosomes and some cells have got less. So polyploidy and aneuploidy can be seen in a cell which is about to undergo malignant transformation. So tobacco is a something which is known to induce aneuploidy within the oral epithelium, which is why tobacco is said to be carcinogenic. Now, aneuploidy and dysplasia are independently predictive of malignant transformation. I mean to say that if you see aneuploidy in a certain cell, you can thereby be sure that the cell is going to undergo some malignant change. Or if you see a high-grade dysplasia, then again, that's again a cellular level change. So that again can predict a malignant transformation. So suppose you've done both the studies, that is, you've done the genetic studies on the DNA level as well as tissue studies on the cellular level to find out aneuploidy and dysplasia. In combination, these have a positive predictive value which is increased in nature. That means independently also they can predict their malignant transformation. But having said that, the predictive value increases when you do both the type of studies together. Now, assessment of both dysplasia and ploidy status of OPMD lesions is very necessary. Now, molecular markers can be used to identify the risk of OPMDs. The genome-wide screening techniques identify DNA aberrations associated with malignant transformation of OPMDs. So what are genomic variations? That is, when a cell undergoes a malignant change, we all know cells can undergo changes like mutations, deletions, translocations, etc. So copy number variations are the abnormal duplications or deletions that exist across large portions of the genome. That is, a certain defect in the genome will be copied a number of times. That means in the genome, in various loci of the genome, you will find the same defect at different places. So that is called as a copy number variations. Loss of heterozygosity occurs in a somatic cell upon loss of genomic material, specifically within the only remaining copy of a functional allele. That means there's only one functional allele and that itself is defective. So that is called as loss of heterozygosity. Now, high frequency loss of heterozygosity can be seen occurring on the petite arms of the 3rd and the 9th chromosomes. And it is correlated with a lot of leukoplakia transforming into oral cancer, which means when you take a biopsy from the leukoplakia lesion of the patient and you take it for some genetic level studies, if at all you're able to see high frequency loss of heterozygosity on the 3rd and the 9th chromosome, the petite arms of the 3rd and the 9th chromosome, that means it is going into, it's a predictive marker for the lesion going into a malignancy. That means the patient has come to you with a leukoplakia. Perhaps clinically it has not manifested into a malignancy as yet, but as a pathologist, you can actually predict that this is going to change into malignancy. So before it does, it's better to remove the lesion. So you can give the clinician your consult about it. Now, dysplastic lesions with p53 overexpressions were more likely to transform into early oral squamous cell carcinoma. So p53 is a tumor suppressor gene, but changes in these tumor suppressor genes can also cause formation of cancers. Now, coming on to the older terminologies. Now, as I said, the oral potentially malignant disorders were earlier classified into two groups, that is your pre-malignant lesions and pre-malignant conditions. So the pre-malignant lesions, I mean, both the groups together are now kept under oral potentially malignant disorders. Now, the pre-malignant lesions are a morphologically altered tissue in which cancer is more likely to occur than its apparently normal counterpart. What I mean to say is, it's a very localized area. Pre-malignant lesion is a very localized area where the tissue is kind of morphologically altered. You can see some change clinically, and cancer might occur more apparently in that part of the tissue. Now, example is a leukoplakia, erythroplakia, and palatal changes with reverse smoking. Now, these were the only 3 examples for precancerous lesions, and we should not confuse smoker's palate or nicotina palatini with palatal changes associated with reverse smoking. because smoker's palate is not a precancerous lesion. It only these three lesions are considered to be. So we will be taking up each of these lesions in detail: leukoplakia, erythroplakia, and palatal changes in reverse smoking. Now, to give you an idea about what it is, leukoplakia is a white colored patch of plaque seen in the oral cavity, and erythroplakia is a red colored patch of plaque which is seen. Palatal changes or reverse smoking is where you hold the cigarette. Patients sometimes hold the burning end of the cigarette inside their mouth, and they can cause burn injuries on the palate. So habitually, when the patient smokes like that, there are changes which can undergo malignant transformation on the palate. So these come under the precancerous lesions. So we'll be dealing with each of them separately. Now, coming on to precancerous conditions. Now, precancerous conditions are a generalized state which is associated with significantly increased risk of cancer. Now, for you all to understand, the difference between precancerous lesions and conditions is that precancerous lesions were localized and precancerous conditions are generalized. So, precancerous conditions can be oral lichen planus, not all types of oral lichen planus, but erosive lichen planus. Then you have OSMF, or oral submucous fibrosis, which is very commonly seen in the Indian subcontinent, disc keratosis congenita, discoid lupus erythematosus, sideropenic dysphagia, that's also a type of iron deficiency anemia. Then you have syphilitic glossitis and xeroderma pigmentosum. So these are the lesions which were earlier grouped under premalignant conditions. As I said, now both premalignant conditions and premalignant lesions are together grouped under oral potentially malignant disorders. Now from this slide, you can very clearly see how the normal epithelium becomes hyperplastic. Hyperplasia is nothing but the increase in number of cells. So from being hyperplastic, they come into the stage of dysplasia. So where dysplasia is there, you can have three stages of dysplasia: mild, moderate, and severe dysplasia. And after severe dysplasia, the tissue goes into carcinoma in situ. And from carcinoma in situ, it goes into a full-fledged cancer or a carcinoma. So you can see that the cancer basically goes through, oral cancer goes through different stages. And in this table, you can actually see the genes which are associated with dysplasias and some genes which are associated with malignant transformation. So actually you can see these molecular markers and predict dysplasia which are undergoing malignant, which will undergo malignant transformation. And when you see these cellular markers, you can be assured that there is malignant transformation in the tissue. So coming on to leukoplakia. Now leukoplakia, as I said, is a white patch of plaque that cannot be characterized clinically and pathologically as any disease, and is not associated with any physical or chemical causative agents except the use of tobacco. Now that's a very important point for you all to note here, because leukoplakia, according to WHO, has to have an association with tobacco. That means it is a diagnosis of exclusion or elimination. It is not necessary that leukoplakia can be actually not always related to tobacco. It has to have a tobacco history. The patient will say that he is using tobacco in either means, by smoking, smokeless, or snuff dipping, anything. But if you see a white patch and you have eliminated all other causes of white lesions, and then you finally end up with use of tobacco, that's what is called as leukoplakia. Now, these are, I've just put up some examples of leukoplakia, where you can actually see a white colored, plaque-like structure. This is a large area, a white colored area, which is seen. This is homogeneous leukoplakia because you can see that it is uniformly white in color. Then you can have different appearances of the leukoplakia. Now, this is again another localized area of white leukoplakia, but then this is more thick and this is not very homogeneous. You can see that it is elevated. It's a plaque type leukoplakia. So what is in common is that in a leukoplakia, it is white in color. Now, the white color can be due to different reasons. It can be due to a thick surface keratin. That is, keratin when wet, that is in a moist condition, will show white color. And if the stratum spinosum is thick, that is called as an acanthotic mass. will mask the underlying blood vessels in the connective tissue. That can also give a white color. So the first reason of the white color is the keratin layer, which has absorbed a lot of saliva or water content in the oral cavity. And the second reason is you have a thick stratum spinosum or acanthotic layer, which has masked the appearance of blood vessels from the underlying connective tissue. Now, the most common precancerous lesion in the oral cavity accounts to leukoplakia. That means in 85% of the cases of precancerous lesions, we can see leukoplakia. It has a very strong male predilection, perhaps because smokers are more in males, because smoking is a major causative factor of leukoplakia. Then you have malignant transformation rate ranging from 5 to 25%, which is actually quite high, because if it is 25%, it means that among 100 people having leukoplakia, 25 of them would go into cancer. So the diagnosis of oral leukoplakia and erythroplakia are made on clinical ground. So the word leukoplakia and erythroplakia are both clinical in nature. So coming on to the etiology of leukoplakia, it is almost always associated with tobacco. So tobacco can be used in different manner. You can use tobacco while smoking. So that is smoking tobacco. Then you have smokeless tobacco. Then you also have under smokeless tobacco, you have tobacco chewing. And then you have this snuff dipping. That is, you can keep the tobacco components in the nasal mucosa and do snuff dipping. So tobacco can lead to combustion end products, which are tars and resins, that is due to smoking, and leached out agents in the tobacco chewing or use as snuff. So pipe smoking is supposedly very harmful, and it has to be differentiated also from stomatitis nicotina. Now, smoking produces nitrosamines, and 80% of the leukoplakias are seen in smokers. It disappears after the cessation of smoking. So the next main causative factor is your alcohol. Now, alcohol has a synergistic action with tobacco. Now, when I say alcohol has a synergistic action with tobacco, I mean to say that alcohol by itself will not cause cancer. But along with tobacco, it will be additive in its role, and it can cause oral cancer. Now, if you've seen society in general, most of the smokers are alcohol consumers, but at the same time, not all alcohol consumers can be a smoker. So most of the times, oral cancer is related to, obviously it is related to smoking, but it can be seen along with alcohol. All right. So synergistic action of alcohol is very important. It doesn't play a major role, but then it definitely plays an adjunct role in alcohol formation. The cancer formation. So now the next point is trauma. Now we all have the habit of cheek biting, lip biting sometimes, but then more or less sometimes people have sharp ends on the tooth, and they wouldn't go to a dentist to get it treated. So habitually, when your tongue keeps touching that sharp area, this can lead to trauma. So as a result of trauma, you can have long drawn ulcers. So ulcers can also be seen due to ill-fitting dentures, like you're wearing a denture and the denture doesn't fit anymore. So obviously the denture causes a lot of friction on the oral mucosa. This can also cause trauma. So now all these things can lead to your leukoplakia. Now this should be differentiated from leukoplakia from frictional keratosis. Now the only difference between frictional keratosis and leukoplakia is that leukoplakia will have dysplastic cells mostly, and on a cellular level, and the frictional keratosis will only have hyperkeratosis. That is, it's due to friction, so there will only be increase in thickness of the superficial layer of the epithelium, that is your stratum corneum. So due to frictional keratosis, you can have a white colored lesion, but when you take a biopsy, you will realize that there's only increase in stratum corneum in the lesion. But in leukoplakia, other than the increased hyperkeratosis or the hyperparakeratosis, you would also see grades of dysplasia in the lower cells. Now, another etiological factor is syphilis. Now, as far as syphilis is concerned, it is a very rare lesion now. Syphilis is a sexually transmitted disorder, which all of you must be aware of. But now syphilis is very rare because penicillin, after the discovery of penicillin, the frequency of the prevalence of syphilis just went down dramatically. So earlier when syphilis was prevalent, it was seen that syphilis was seen during, the leukoplakia was seen in cases of syphilis. Now, coming on to vitamin deficiency. Now, vitamin deficiencies can cause a lot of diseases. Now, vitamin A deficiency can cause metaplasia and keratinization. So, increase in keratinization can be seen when the level of vitamin A goes down, or you can see metaplasia. Metaplasia is basically change of one type of adult cell to another is called as metaplasia. So, vitamin A deficiency can not only cause metaplasia, but also cause increase in keratinization. Now, vitamin B complex can alter the oxidation patterns in the epithelium, making it more susceptible to irritation. So, which is why vitamin supplements are very important to be given to these patients. Now, hormones also have a lot of keratogenic effects. Now, keratogenic effects of sex hormones are well documented. So that means there are certain sex hormones which are increased in levels can cause leukoplakia-like changes. Now, the next is candidiasis. Now, speckled type of oral leukoplakia shows hyphae of candida in the superficial layers. Now, that's something called as candidiasis is a fungal lesion, as we all know. Now, type of candidiasis, there's one specific candidiasis called as candidal leukoplakia. Now, candidal leukoplakia is basically the basic difference between leukoplakia and candidiasis. Both are white lesions. So the basic difference between both of them is that a leukoplakia is a thick plaque-like structure which cannot be scraped off, and it is associated with tobacco. But candidiasis is a white lesion where you can actually scrape off the white area and leave bleeding points on the white area. So that is a fungal lesion, that's candidiasis. But sometimes you find a lesion which cannot be scraped off but also has candidal leaves on it. So that is called as candidal leukoplakia. So we really don't know whether the candida caused the leukoplakia in the first place, or the leukoplakia was already present and the candida came on it after that. So that is also a very special etiological factor. Now the next etiological factor is sanguinaria. That is, these white lesions can occur in people when they start using toothpaste and mouthwashes which contain some herbal extracts, and maybe it's a hypersensitivity reaction that the patient does not adjust to that herbal extracts and can have these white colored areas. UV light can cause actinic cheilitis. Cheilitis is the inflammation of the lip. So UV light can cause this. And when UV light is a causative factor, you can see the leukoplakia on the lower lip vermilion border, because your lower lip is more prominent when compared to the upper lip when you look at your facial profile. So as a result of which, you can see more of these oral leukoplakia lesions in the lip vermilion border. Then diet also has a major role to play, where you have very low antioxidant levels. That is when you can develop these kind of lesions, when your immunity goes down. So, which is why when a leukoplakic patient comes to you, you have to prescribe a vitamin B complex and antioxidants to them. So that's about the etiology of leukoplakia. One major etiology which I did not include in that list and now I'm including is HPV. HPV is nothing but human papilloma virus. Now, human papilloma virus basically shows the change in an etiological trend of oral cancer per se. So since leukoplakia is a pre-malignant lesion or an oral potentially malignant disorder, HPV needs a special mention. So earlier, we used to find patients walking into the clinic with oral cancers who were very old smokers. They were old males and they used to smoke, and they've smoked all their lives and they've had problems. They've initially had a white patch like a leukoplakia, then suddenly, over years together, they did not bother about it. It became ulcerated, and then, the ulcer never healed, and then it started proliferating, and then they would come to you with an oral cancer lesion. But in case of an HPV etiology, the age and the, the history of the patients go to the other extreme. In the sense, you can have a patient walking into your clinic with a lesion, a wart-like lesion, or ulcerative lesion on the, pharyngeal region, oropharyngeal region. And the girl, it might be a girl, a young girl who's like hardly 15 or 16-year old, but then is sexually active. But she might not have just smoked a single cigarette in her life, but has come up with a squamous cell carcinoma. That can be because HPV is a human papilloma virus, which are of two types. There are different types of HPVs, which are high risk type and low risk type. Now, the low risk type HPVs can cause lesions like benign oral proliferative epithelial lesions, squamous cell papilloma, common wart. Warts are those small warty projections which you can see on your hands or legs or anywhere in friction. Then condyloma accumulata and Hex disease. So these are benign lesions which a low risk HPV can cause. But then a high risk HPV can cause oropharyngeal carcinomas or precancerous lesions. All right. So these are showing you the change in etiology in the common in the modern era of oral cancer. So what does the HPV do? HPV has a lot of these proteins, virally encoded proteins, early proteins, E6, E7. So they bind simultaneously to the ubiquitin protein ligase E6AP and P53, resulting in ubiquitination of P53 and its subsequent proteolytic degradation. So that's the pathogenesis, as in how the HPV is going to work. Now, screening measures are available for cervical cancer, such as Pap test and HPV polymerase chain reaction test. Now, you might ask me, cervical cancer is cancer of the human female genital organs. So why is that important in an oral cancer? It is important because HPV not only can cause cervical cancer, but it can also cause oropharyngeal carcinomas. So the same detection techniques, that is your HPV PCR or a Pap test, can be helpful in detecting an oral cancer caused due to HPV. So that is why cervical cancers and oral cancers can have a lot of these similarities. Now, there are some vaccines which are available for HPV these days, but it's very questionable whether to take the vaccine or not, because half of the gynecologists say that the cervical cancer comes due after, giving the vaccine, and some of them say that you can actually ward off the disease because of the vaccine. So that's a very questionable thing to do. But having said that, there are many people who take the vaccines nowadays. So studies have to be initiated to determine whether prevalence of oral carcinomas decline along with the expected decline in cervical cancer in women who receive the HPV vaccines at a very young age. So coming on to clinical features of leukoplakia. Earlier, it was thought that leukoplakia was always seen over 40 years of age, and it increases in a gradient manner with age. But as I said, HPV has changed the whole, design of the age trend. It can be seen in younger people as well. So this was earlier seen more in males, but now that the gender predilection can even be equivalent. So the sites are lips, buccal mucosa, and gingiva and the commissures. It can be seen anywhere. More commonly, it was earlier seen where the patient used to keep the tobacco pouch inside the oral cavity. It can be mostly in the labial mucosa or floor of the mouth, or in the buccal vestibule and things like that. Then clinically, you can actually see either a homogeneous lesion or a non-homogeneous lesion. Now, when I say homogeneous lesion, I mean to say it's a flat white lesion, which can be either early lesion or it can be a thin leukoplakia. And then you can have a thick leukoplakia, which is actually thicker like plaque. The pictures which I showed you were thick leukoplakias. Or it can even be non-homogeneous. When I use the word non-homogeneous, I mean to say that it's just not white in color, but it also has some alternative red colors in between. Or you can also find a verruciform appearance. So whenever you hear the word verrucous, always remember it looks like a cauliflower-like surface. So cauliflower-like appearance is called as a verruciform appearance. So or you can have a proliferative verrucous leukoplakia. Now, PVL is a very specialized type of leukoplakia, which we'll be dealing separately, because it shows a 70% malignant change. So this is a verruciform leukoplakia, as I said, that it has a cauliflower-like appearance. You can see that the surface looks like a cauliflower clinically. So this is a homogeneous thick leukoplakia, where you can actually see that in the floor of the mouth area, this is the floor of the mouth area, and you can see that it is homogeneous. It's continuously white in color, homogeneously white, uniformly white in color, and it's extremely thick. It's not a thin lesion, all right? So then you have granular leukoplakia, where you can actually see that there are red and white areas in the picture. So a non-homogeneous type of leukoplakia shows an increased risk of malignant transformation. So having said that, homogeneous and non-homogeneous leukoplakia will show malignant transformation, but there are chances that it will both show transformation. But if you compare the non-homogeneous type to the homogeneous type, I would rather say that the non-homogeneous type would show a more increased risk to malignancy. And the homogeneous one, I've already told you, is a very uniformly white lesion. Now, depending upon how thick it is, it can be initially macular, that is, you can just see the white area and you can't really palpate it. Sometimes it is papular, that is, it is larger in size, so obviously you can feel it. You can not only see it, but you can also feel it or palpate it with your fingers. It can be translucent, fissured, or wrinkled. So all these fissuring and wrinkling comes in when the thickness of the leukoplakia increases. So it might have sharply demarcated borders. Now, a speckled leukoplakia, as I already told you, is not a homogeneous leukoplakia. You will see areas of white and red areas alternatively. So that is called as a speckled leukoplakia. Now, nodular or granular leukoplakia, again, will have either raised areas and smoothened areas, side by side, or white areas and red areas side by side. So that's about the clinical features. So this is a pictorial representation from the book Neville, where you can actually see the changes in the epithelium and in the connective tissue taking place. So that's a normal epithelium, and it became hyperplastic, that is, increased the hyperkeratosis on the epithelial end. And then you can see that these small, the epithelial cells have increased in thickness. And these black dots are nothing but your host reaction, that is your lymphocytes, which have come from the connective tissue. So the moment the body realizes that there is something wrong which is happening on the epithelial end, immediately from the blood vessels, your inflammatory cells will go for protection. So you can see that the epithelium gradually increases in its thickness. And as it increases in its thickness, it also becomes fissured. That is, it becomes very irregular in shape and structure on the uppermost layer. And when it goes towards the end, you can see that this red area shows ulceration. They break down, the epithelium breaks down. So what are the changes? These are changes in the clinic that you can see on the patient when the patient sits on the chair. But when what you don't see is what happens in the connective tissue, because connective tissue is under the epithelium. So gradually, as epithelium increases thickness and it goes on to ulceration, your connective tissue cells also will increase the lymphocytic infiltration in the juxtaepithelial region, as you can see. Plus, the amount of dysplasia increases inside the epithelium. This is not visible by the naked eye, but then if you take a biopsy in each of these stages, you can actually see that the number of dysplastic cells which were earlier seen in the lower third of the epithelium is now seen throughout the thickness of the epithelium. So that is a pictorial representation. Now coming on to the verrucous leukoplakia. Now verrucous leukoplakia, talking about verrucous leukoplakia, whenever I said that when you hear the word verrucous, you should think in terms of a cauliflower-like appearance clinically. So a cauliflower-like appearance would be a very, I would say, not a very uniform appearance. It would be an exophytic lesion. So when I say exophytic lesion, it means that it rises above the surface. So with irregular, sharp or blunt projections, with an elevated, proliferative or corrugated surface. So all these words, corrugated, exophytic, verrucous, all these things show papillary. They all show that they're proliferative lesions towards the outer part of the epithelial surface. Now, proliferative verrucous leukoplakia is a very important lesion to know. It's a progressive type of verrucous leukoplakia, and it's a very long-standing lesion, and it undergoes 70% of the lesions can undergo a malignant change. So it's very important to know these lesions from that aspect. So the early lesions are seen as a solitary homogeneous plaque, and there is female predilection and minimal tobacco use, which means that this is a very long-standing lesion, but then it is associated with a minimal use of tobacco and predilection in females. It is confluent, multifocal, widespread oral keratosis with stubborn recurrences and persistence with a high frequency of malignant change over a period of years. What I mean to say is that this will be, the patient will come to you with the first lesion, which will be a single white area. And if he or she does not undergo any, change of these lesions, it will continue, it will stay like that. So it has minimal tobacco use etiology and female predilection. So, but then it is very stubbornly recurrent. That means even if you remove the lesion, the patient will come with a recurrence, and it will persist over a long period of time, say for 15 years altogether, it will persist. And suddenly it will come up as a malignant lesion. So after a period of years, it can become malignant. So the clinical staging of oral leukoplakia is also called as a OLEP staging system. Now, always remember that staging is always clinical and grading is histological. So the grading system is histological, wherein we grade it as, on a biopsy, we would grade it as a high grade, low grade, or a intermediate grade lesion. Whereas staging is a clinical system where in the clinic, the clinician would kind of give certain, parameters and consider it to be a certain stage. So L1 are those lesions which are less than 2 centimeters in size, and so on and so forth. And LX is where size is not specified by the clinician. PO shows there's no epithelial dysplasia, and P1 shows there's a distinct epithelial dysplasia. Now, this epithelial dysplasia can be seen in a biopsy, and PX's dysplasia is not specified in the pathology report, in the biopsy report. So a stage 1 lesion will be, it's a combination of both pathological and clinical parameters. So a stage 1 is L1 PO, and L2 PO is stage 2. L3 PO or L1, L2 P1 is basically stage 3, and L3 P1 is stage 4. So the Sharp described 3 stages of leukoplakia. That is, to put it in simple words, initially you can basically see the white color, but you can't really feel it. And that is a macular area. So it's a non-palpable area where you can actually see the coloration, but you can't feel it. So that is a non-palpable area. The other is, so you can call it as a macule. The other stage is where the proliferation becomes slightly more in nature, and it can, then you call it as a papular area. So there is a localized or a diffuse elevated plaques with irregular outline. Then you have a thickened and indurated white lesions which are fissured or ulcerated. That means this is a papular area where it has increased in its thickness. So as a result of which, not only that you can see the white area, but you can also feel it with your fingers. So you can palpate it. It's due to the thickening or the induration. So after once it becomes palpable and it increases in its thickness, it can undergo fissuring and ulceration. Fissuring is like the irregular areas on the surface, and then you can even see ulcerated areas. So leukoplakia in the floor of the mouth will show malignant potential, maximum malignant potential. So that is because the floor of the mouth has got an epithelium which is very thin in nature, and it is non-keratinized and very loose connective tissue below it. So the maximum absorption of even drugs can take place through the floor of the mouth mucosa. So it is the same thing that can be seen here. The malignant changes can also be seen very easily in these cells. So histological features. Now, histopathology of leukoplakia is extremely important because basically we speak about dysplasia here. So step by step to discuss the histopathology, we can first think about the first layer, that is your stratum corneum of the epithelium. So stratum corneum is the superficial most layer of the epithelium, and it can sometimes show increase in keratin. So increase in keratin, and that too moist area, keratin in the moist area, which is why it is white in color. So the hyperparakeratosis or hypoorthokeratosis are seen in this stratum corneum. So depending upon whether there's a pycnotic nuclei, you call it as a parakeratotic area. And when there is no nuclei, it is only keratin that you find, you call it as a orthokeratotic area. So how can you, another point where you can differentiate the hyperorthokeratotic area is, you find a very prominent stratum granulosum, the granular layer just below the orthokeratinized area, which is very much absent in a parakeratinized area. So the next layer, which is below the stratum granulosum, is your stratum spinosum. So that is also called as an acanthotic layer. So you find an increased layer of thickness of the acanthotic layer, and sometimes you can even see atrophy of the epithelium. Sometimes you see papillary projections. So when you hear papillary, you should always remember finger-like projections seen towards the surface of the epithelium. And you find dysplasia. So that word dysplasia is like, you know, dropping a bomb, because when you hear the word dysplasia, immediately you should understand it can be either mild, moderate, or severe dysplasia. So depending upon how much dysplasia that tissue is kind of showing, that will determine the malignant potential of the tissue. So coming on to dysplastic features. Now there are many features of dysplasia which are enlisted in the literature. So it's very important to understand each of these features. Now the first feature is nuclear and cellular pleomorphism. So from the word we know, pleo means poly, many, morphic means size and shape. So nuclear and cellular pleomorphism means that the nucleus as well as the cell can be seen in varied shapes and sizes. Means there is no uniformity in the size or shape of the cell or the nucleus. So that is called as a nuclear or cellular pleomorphism. Next is increased NC ratio. Now, nucleus divided by cytoplasmic ratio is basically the NC ratio. So in a normal cell, we find that the size of the nucleus is basically very small, and then the cytoplasm is large when compared to the nucleus. So a normal NC ratio is 1:4 or 1:6. I mean to say, nucleus occupies only one part of the cell, whereas cytoplasm occupies 4 parts of the cell or 6 parts of the cell. But what happens is, in dysplasia, the nucleus starts to kind of divide and proliferate all the more, as a result of which the DNA content or the RNA content in the nuclei will actually increase. So the size of the nucleus will keep on increasing when the proliferation of the cell will start to increase. So as a result of which, your nucleus will start becoming more bigger in size. So it will reach a stage where the nucleus fills the entire cell and the cytoplasm is just rimming the surrounding areas. So that is called as increased nuclear cytoplasmic ratio, which a maximum can be 1:1. That is, the nucleus can be of a similar size as that of a cytoplasm. So the next option is, the next point is nuclear hyperchromatism. So the word chroma means color. Hyperchromatism means the nucleus is showing more of color. So what color do you use to stain the nucleus? You use stains. So hematoxylin and eosin stains are what you use to stain the slide. So as you all know, hematoxylin is blue in color and eosin is pink in color. So what happens is, your nucleus is basically an acidic structure. That is, it contains deoxyribonucleic acid and ribonucleic acid. So basically RNA and DNA are present. So if it is acidic in nature, it will obviously attract more basic stuff to them. So the basic stuff that it will attract is going to be a basic stain. So the hematoxylin or the blue colored stain will immediately go and attract towards the nucleus. So it will stain the nucleus dark blue in color. So when you see increased staining of the nucleus, it means that more of stain has gone and attached to the acid content, which means there is more of acid content, which means there is more of DNA content. So that is nuclear hyperchromatism. So dyskeratosis, that normally where you find keratin? You find keratin in the superficial layer of the epithelium, that is your stratum corneum. So dyskeratosis is where the keratin is not seen at the topmost layer of the epithelium. Instead, you are able to see the keratin right in the lower layers as well. When you find keratin in say stratum spinosum or granulosum, or even before that, you call it as premature keratinization. So that is called as dyskeratosis. So it's a pathological type of keratosis which is not normally seen in the lower layers of the epithelium. So then you can see a prominent nucleoli. So nucleoli are nothing but the the condensation of chromatin inside the nucleus, where you find a more darker spot inside the nucleus is called as a nucleoli. So the nucleoli will be very prominent, and it might be even increased in number. So this is another feature of dysplasia. The next feature is abnormal or increased mitotic activity. Now there are two things one has to understand over there. When I say abnormal mitotic activity, I mean to say that mitotic activity is seen in a position where it was not earlier seen. What I mean to say is, mitosis is normally a function of the stratum basale. That means the lowermost layer of the epithelium will be undergoing mitosis normally. So when you see mitosis in superficial layers, that is in a xanthotic layer or in stratum granulosum, that is when you call it as an abnormal mitosis. Now, abnormal mitosis can also be called in another way. What I said is earlier that one cell would form two daughter cells. So that is a normal mitosis. An abnormal mitosis would be one daughter cell being, stretched apart into three parts, three daughter cells, which means that there will be aneuploidy. There will be no uniform, kind of sharing of genetic material. So that can also be called as abnormal mitosis. So there are 2 points to remember. Abnormal mitosis can be either seen in an abnormal location, or you can see it as an aneuploidy. That is, you can see unequal sharing of genetic material between the daughter cells. Then you can see increased mitotic activity. Suppose you only find 10 areas of mitotic activity in a field normally, but then here you're finding 100 areas. So that means it is increased mitotic activity. So that is also a feature of dysplasia. Then comes poikilocarinosis. Poikilocarinosis is kind of a syncytium where you have the nucleus which is divided, but cytoplasm has not divided. Okay, so you have a lot of these nuclear content very irregularly arranged inside the cytoplasm, which is uniform, and only single area of cytoplasm with a divided nuclei. So then the next dysplastic feature you need to know about is basilar hyperplasia. Now, basilar hyperplasia again is a very normal feature that you find in the basal cells. When you see basal cells, you'll always find that there are 2 or 3 layers of basal cells normally. But when you find increased amount of basal cells, more than these 2-3 layers, that is when you call it as a basilar cell hyperplasia. So as a result of which, this will cause a teardrop shaped retapex. Now, when you imagine a teardrop, we all know then that a water droplet, when it falls down, it has a large base and a small upper area. So a teardrop shaped retapeg is a retapeg where there is increase in cellular proliferation at the lower border, and the upper border of the teardrop is more thinner in nature. So that can happen as a result of basilar cell hyperplasia. That means unequal division of basal cells in the basilar area can cause a teardrop shaped retapeg. Now, the next is loss of cellular polarity in the basal cells. Now, we all know that every cell has got a certain axis, a longitudinal axis. So suppose whatever the axis is of the basal cell, your cell will divide in that direction of that particular axis. So sometimes there is loss of this axial arrangement. So that is called as loss of basal cell polarity, which means the basal cell might, kind of just hinge towards one side. So when the basal cell hinges towards one side, what happens when it, proliferates, it will also hinge towards that one side. So the tissue proliferation will also be very unequal in nature. So the next is abnormal maturation. So when I say abnormal maturation, I mean to say that there's a loss of stratification pattern. Now, when we talk about mucosas, there is a certain stratification pattern. That is, you have the lowermost, stratum basale, followed by stratum spinosum, then stratum granulosum, and then stratum corneum. So that doesn't seem to be in a very uniform manner. So that is called as loss of stratification or abnormal maturation pattern. So coming on to the next dysplastic feature, that is aberrant keratinization. Now, as I said, when you find keratinization in the lower part of the epithelium, it is called as dyskeratosis. Now, aberrant keratinization can also be called as an individual cell keratinization, where there is only one single cell that is keratinizing. It does not form a keratin pearl, but there's a single cell which is keratinizing. So many such cells which keratinize together can give rise to a keratin pearl later on. Then you have loss of cell cohesion. Now, we all know that the epithelial cells have this uncanny ability to be very close to each other. They have these cell junctions. But when there is loss of cell junctions, you call it as loss of cohesion. And loss of cohesion is actually seen as a prelude to, development of oral cancer. So now these are different pictures which are available on the internet, which shows different types of stages of, tooth, the cell division. So you can see how two daughter cells are forming from the same cells. So now coming on to the dysplastic features, you can actually divide the dysplastic features into architectural features and cytological features. Cytological features will pertain to the one single cell, and architectural features will pertain to the entire architecture of the tissue. That is from stratum spinosum or stratum basale to spinosum to granulosum to corneum. So the feature, we've discussed all these features, but we can see that a few features come under architectural features and a few of them come under cytological features. So depending on the cytological features and the architectural features, we can have grades of dysplasia. So I said that the histological grades are basically divided according to what you find in the biopsy. So you have mild, moderate, and severe dysplasia, depending upon to which layer you can see your dysplastic feature. So when the dysplastic feature is seen at the lower third of the epithelium, you call it as a mild dysplasia. When you find it at the lower third and the middle third, it is called as moderate dysplasia. When you find it in the entire thickness of the epithelium, then you, from the lower third to the middle third through the upper third, but not exactly involving the entire thickness, you call it as a severe epithelial dysplasia. And when it occurs in the entire thickness of the epithelium, you call it as carcinoma in situ. That is bottom to top changes, because you find the entire epithelium being affected by dysplasia. The next stage is, after carcinoma in situ, if it does not stop, the next stage is a carcinoma or a full-fledged oral cancer, where there will be invasion of the dysplastic cells into the connective tissue. So all leukoplakias, therefore, should be viewed with a lot of suspicion. So that was about the, clinical and histological features of leukoplakia. So in the next class, I will be dealing with the grading features of dysplasia, as well as erythroplakia and the rest of the oral potentially malignant disorders. Thank you so much for a patient listening.